All right. Welcome to the Medical Association of the State of Alabama's Facebook Live. My name is Aruna Arora. I'm the president. I'm here today with some experts. Of course, every week we have Dr. Scott Harris, our state health officer, but we also have three other guests. We have Dr. Michael Saag, well known to everybody as our ID expert at UAB. We've got Dr. David Thrasher, pulmonary critical care physician out of Montgomery. And then we have Dr. John Meigs, our past president of the association and a family physician in Bibb County. So welcome everybody. I'm gonna go ahead and let Dr. Harris, you wanna go ahead and give us an update?
Sure. Thank you very much, Dr. Arora. It's really good to be with you guys again. This is about the fifth one of these I think we've done. It's good to come back every Thursday afternoon and have one of these presentations. I just want to remind people that we intend to keep doing those. So please come back again next week on Thursday at 4 o'clock Central, and we will bring you another presentation. We are continuing to have a pretty difficult time in the state right now. Our numbers of patients in Alabama hospitals are approaching our all-time high. We're not quite there, but as of today, we're just under 2,900 inpatients in the state of Alabama. We got just over 3,000 back in January, and I have to tell you, that was about as much as our hospitals were able to handle. It was a really difficult time then, you may remember, and we are just a little over 100 patients below that number. We have been increasing steadily for really for about 6 weeks now. One thing that we had not experienced before, even in January, was such an overwhelming number of critically ill patients who need to be housed in the ICU. As of today, we actually have 40 more patients in Alabama hospitals who are receiving critical care than we have actual ICU beds assigned in Alabama. That is, there's at least 40 patients who are being treated with a critical illness in somewhere other than a normal ICU setting. They're being held in their emergency department. They're in a regular room that's been converted to an ICU room. They may be on a gurney in the hallway trying to receive critical care. It is a really, really difficult time right now. Much of the surge has been fueled by what was going on in the southern part of our state. We were seeing a lot in Mobile County and Baldwin County, over in Houston County, where Dothan is. But now we're beginning to see those numbers everywhere. There are just a handful of actual open ICU beds in the state. We have a total net negative number, but there are about a dozen or so beds that are scattered around the state. It's just that we have so many excess patients in the southern part of our state that we have that net negative. We actually have a net 40 number of ICU beds. So that's a really difficult situation. That's not the ideal way that we would want to have people taken care of in our state. And it's tremendously difficult for the men and women that are working in our hospitals, the doctors and nurses and respiratory therapists and other staff members. It's been a tough year and a half for them already, and these surges just make it that much more difficult for them. And so that's really a challenge. As we have been seeing all along, the hospitalization numbers in our state are being driven almost exclusively by people who are unvaccinated. We do have about 11 or 12% of the people in our hospitals are people who are fully vaccinated. So there certainly are some, but around 90%, almost 90% are people who are not fully vaccinated. And in terms of our deaths are almost exclusively occurring in people who are not vaccinated. So we've known for a long time that these vaccines aren't perfect. It's certainly possible to get infected even though you may have been fully vaccinated, but people who are fully vaccinated rarely end up in the hospital, and they almost never die. The vaccines are very protective even if you should happen to get infected. We are concerned about what's going on with our schools coming back into session. Most all Alabama schools now are back in session, and that gives us a lot of trepidation. We looked at the first couple of weeks of school this year as compared with the first couple of weeks last year, and the numbers are just staggering. This time a year ago, in the first 2 weeks of school, we had just over 700 cases among our age 5 to age 17-year-old group. That's not necessarily saying those occurred in the classroom or in schools. There were a lot of kids doing virtual school at that time, but we had just over 700 cases. In the same 2-week period this year, we have 5,571 cases. So that's a 700% increase this year compared to last year. So we again want to remind people that everyone needs to be vaccinated who's eligible. That's everyone age 12 and up. We strongly recommend universal masking in schools. One of the ways to stay in school, if you're exposed to a case, is to be in a setting where you're consistently masked and you're staying at least 3 feet apart. It's very important for us to keep children in school, but we absolutely have to find a way to do that safely. The final thing I'll say, Dr. Arora, is we are encouraged by the vaccination numbers. We are seeing vaccine numbers go up. Thankfully, better late than never, I guess. But we want to encourage people who are watching, please don't wait any longer to get vaccinated. The people who go and start getting vaccinated today will need another shot in 3 or 4 weeks and a couple of more weeks after that to get full protection. So our state really doesn't realize the benefit of that vaccination that you start today, really for a month and a half. So please don't wait any longer. If you have questions about whether vaccination is right for you, please talk to your doctor. Please talk to your healthcare professional to find out what's right for you. So that's all I had prepared, Dr. Arora. Thank you very much.
Yeah, you are so welcome. I have a couple of questions. One, in terms of Baldwin County and the southern region of our state, Dothan, can you describe a little bit about what's happening? I know Baldwin County did receive the federal team last weekend. How are they doing? How long are they here? And then Dothan has a federal team also arriving.
That's exactly right. We have been trying for several weeks now with our federal partners to find resources we could bring to the state. And when I say resources, I really just mean people. We need warm bodies who can come and work in Alabama hospitals. Our hospitals are actually well equipped. We have plenty of ventilators in just about every case. So they are doing very well in terms of other types of supplies, but it's really hard to find people to work. So we had a team arrive this past weekend for Baldwin County. It was a team of about 14 people. They're here for about 2 weeks officially, but then we will continue to try to extend that. And so hopefully we can extend that for as long as this surge continues. We have another team that's scheduled to come this coming weekend that will be going to Southeast Medical Center in Dothan. It's about the same size team. They're also scheduled to be here for about 2 weeks. Normally, these teams would be civilians. The HHS would go out and recruit doctors and nurses from the private sector and hire them to come in. There are none of those people out there. And so, interestingly, we're actually receiving active Department of Defense troops. These are people from the Air Force who are medical professionals who are actually coming on this mission to come to Dothan. So we're very grateful we had them. We have made several other requests for several other teams and have been effectively approved to receive those teams, but there are just no people to send right now. So hopefully we'll get some more soon.
Okay, thank you. So as we all know, there are 3 different parts of public health, and we cannot overstress the preventative side, which Dr. Harris has alluded to with the masking, especially in the children. Because some of the other things that we have in our toolbox are not available to all children. So the masking in the schools is something that we cannot stress. UAB just came out with a beautiful observational study with the healthcare workers. And so, it really would be a shame not to pay attention to this data that we have in our state to protect the children who may not have an option for the other things that we are going to talk about. Vaccines, that is the middle, and so we cannot stress the importance of continuing to get your vaccine, the first and the second dose. I just saw a schematic out of Cleveland Clinic that I really enjoyed, and it had, the first, which is the defensive driving, the preventative, the washing your hands, the wearing your mask, and then it had the middle where you wear your seatbelt, which essentially is your vaccine. And then the last, which is if you did get into an accident, the airbag deploys. And that's what we're about to talk about. We're going to talk about that last step, that if you did get COVID, if you got exposed to COVID, the monoclonal antibody treatment. And so Dr. Saag, can you please get us updated on some of the state and the UAB data and national data for us?
Well, I think Dr. Thrasher might have more details about the state, but I'll just say in general, monoclonal antibodies are basically antibodies or proteins that are designed to bind to the virus and take it out of circulation. When given early in the course of an infection, that is day 1, 2, or 3 of symptoms, certainly before day 6, you get the maximum benefit. And what it does is it shortens the duration and reduces the severity of illness significantly, keeps people out of the hospital. The data from the study show that about 70-75% of people who were caught early and treated that way did not need to be hospitalized. And that's huge, especially as you heard the data from Dr. Harris, that our hospitals are becoming overwhelmed. So this is a way that we all can help. The messaging to patients is, number one, get vaccinated, get it done now, as we just said. The second thing is for them all to monitor for symptoms. And if they have any symptoms, they think even have a hint that might be COVID, get tested right away, because then your doctor can know and get you referred to monoclonal antibody. The clock starts on the day of onset of symptoms. So when I say day 1 or 2 or 3, that's the day after the first symptom appear, be it a runny nose or sore throat or body aches. Fever usually comes later. This is the type of thing that we want to track to. But Dr. Thrasher, maybe you can talk about your experience and what you see happening statewide.
Well, Mike, it's tough, as you know. We're overwhelmed in the hospital. We're out of ICU beds, and my ICU is just full of 20 and 30-year-olds and a handful of 40-year-olds. This is a younger demographic. It breaks my heart because the 95% of these are unvaccinated. And like I've said, once you're in the hospital, I don't have a lot of bullets in my gun, okay? I consider the patient in the hospital as my failure, the Medical Association's failure for not getting them earlier. Like Dr. Saag said, if we can get them in that first 10 days, we got a really great chance. Most of these people will not have to be hospitalized, and very few of them will die. The volume is incredible. Here in Montgomery, our centers, both at Jackson and Baptist Hospital, in June, we did, I think, 4 infusions that month. In July, we did 100. And after this week, we'll have done 2,000 infusions this month alone, and trying to even double that. And what we've got to do, Mike, is just get more and more of these people, like you said, calling their doctors early. Don't wait till day 6 or 7 to call us, because it may take me 2 or 3 days to get you in the infusion center.
Okay, so can we go over some of the criteria for who qualifies for monoclonals? I know this has changed over, the past year, and there is some confusion. A question came in about some centers denying people who are under the age of 55.
You want to take that, Mike?
Well, I mean, so the monoclonals are really now eligible for pretty much anyone who has an underlying condition, especially if they're overweight, if they have an underlying health condition, diabetes, high blood pressure. Look, the bottom line is the old rules that had people over the age of 55 or 65, most of them have been vaccinated in our state. So we don't see many of them anymore unless they've got a significant underlying disease. But it's really meant for most anyone who has an underlying condition of any sort. And so we've really liberalized the eligibility criteria.
In Alabama, Dr. Arora, it's a BMI of 25. That's way below Alabama's average BMI, I have to say. So there are a lot of people that are covered by that of all ages. And I guess I don't have to remind you, Alabama has more than its share of chronic disease anyway. So we certainly do have a lot of people who are eligible just because of either their size or their other underlying health problems.
And just to emphasize that, the people that we've noticed from the beginning, people who are overweight do worse with their COVID infection. That's just a fact.
That's so true, Mike. The ones we have in the ICU, the younger patients, if they're significantly overweight, they have COVID, the chances are not great if they go on the ventilator of survival. Excuse me, John.
Yeah, I was going to say the thing about being pretty liberal with who qualifies for the monoclonal antibodies is it's sometimes hard to predict who's going to get really sick. These young folks that don't have a whole lot of problems, they can still get really sick. So I've I don't turn down many folks.
Dr. Meigs is exactly right. You can't predict the first week I say everybody's fat and happy. They say, oh, this isn't bad, it's like the flu. Then you fall off the cliff the second week. You just don't know who's going to get sick. I say if you're over the age of 12 and you live in Alabama, you probably qualify. And for the reasons that Dr. Harris has already said. One thing I want to say about you, we're on Facebook, and so I think 75% of Facebook of medical information has been proven to be misinformation. One myth that I want to dispel right now, that the latest the Facebook myth, two folks were coming on and saying, use ivermectin because the monoclonals do not work. And they quoted, they said the bamlanivimab, which is Eli Lilly's first approved product, has been taken off. It doesn't work, it's been taken off. And they quoted another study called the Blaze study, says it shows that the monoclonal antibodies do not work. Well, again, this is misinformation. The bamlanivimab was not taken off. It was replaced by Eli Lilly to the second generation, what's called BAM80, which worked better, okay? And BAM80, we don't use in Alabama. It's still a great drug. It's available. The reason we don't is we have a small percentage of gamma variant in Alabama. The Lilly product does not get gamma. The Regeneron product, and that's what we use here, gets gamma and delta. The Lilly product gets delta very well, but we can't gamble that you're the 3% that may have had the gamma variant here. And they talk about the Blaze study showed it didn't work. Well, what that study was talking about, we tried to see if this worked in the hospital. We found out it does not work in the hospital for the reasons Dr. Saag said. You have to use it early. And that's the first 10 days, preferably the first 5 days of symptoms. And by the time you get in the hospital, it's usually past that.
Right. So 2 points about that. We've talked about this on this type of broadcast where it's worth reiterating. There's 2 phases of this infection. The first 6 days or so is a viremic phase, and the second is an adaptive immune response phase where a lot more damage is done because of collateral damage from the immune response. In that first 6 days, that's really the key. That's when the virus is replicating, and that's when the monoclonals have the most activity. A question that commonly comes up, what if somebody's already vaccinated? Can you give them a monoclonal? Yes, you can. And it's passive immunity on top of active immunity, and that has a double effect. So in our case, we've been triaging a little bit because we're seeing up to 21 to 22 patients a day in our monoclonal clinic, and we're triaging towards the people who are unvaccinated and who are at higher risk. But if somebody's vaccinated and has risk factors, we're giving them that as well.
That's good to know. A lot of people are asking about whether this medication requires any sort of fee.
And the answer is no, not to the patient. The provider has the ability to bill insurance or others, but not to the patient.
And then how soon after receiving the monoclonal do people start to feel better?
Some
Very
the same
quick.
day, usually within 24 to 48 hours. But a lot of, we've given it to some and call and check on them that night, and they already can tell they're starting to feel better. But again, I want to stress, if you can give it in that first 5 days. Now, after you get past a week, it might help, but it doesn't help like it does in the first 5 days. I mean, you give it to them in the first 5 days, we're keeping folks out of the hospital.
That's right. The people that we've been seeing be admitted, and there are some who get monoclonal and then get admitted, are almost invariably the people who are showing up after day 6 of symptoms. Sometimes we're admitting from our unit because it's day 8 or 9, and they're right on the verge of their oxygen levels dropping. And then while we're seeing them, they kind of take a turn for the worst, and we just put them in the hospital from there. But like Dr. Harris said at the beginning, our bed space is really becoming limited. And so don't wait, come in early, get your treatment. First off, get your vaccine. I can't say that enough. But if you do get sick, get in early. And if you're going to get monoclonal, that'll keep you out of the hospital, certainly if you're getting in the first 5 days.
If I can say one thing, Dr. Arora, so we are listing all the monoclonal sites available in the state online so that people can see where those are located. There are over 150 locations now giving them. However, this is a decision you need to make with your physician or with your healthcare provider. This is not something that you would just walk up to, just like as if you were deciding to get a test yourself or to get a vaccination. A physician needs to prescribe this medication for you. And so it is something that we want people to work through their healthcare provider to understand if it's right for them.
Thank you for clearing that up. I know, we do have a neighboring state where that is not the case. And so there is some confusion with patients in our own state on the process that they need to follow. But again, this is purely for the optimal time period of what you all have described for when the treatment is to be given. If you just walk in, some patients are walking in when they really are beyond the state of getting the benefit of the monoclonal and probably need hospital attention.
Dr. Roy, can I make one point on that too? Absolutely. Yeah. Call your healthcare provider and ask them if you qualify for the MAB. If they say no, ask them why. A lot of this is new. This is new technology, if you will. Okay, and we can't expect all the doctors to know all that's happening. A lot of them are looking at last year's criteria. Well, he's not 55. He's doesn't have a BMI of 35. So if they say no, politely ask him why. And then if you're still not sure, maybe get a second opinion.
That's good to clarify. Thank you, Dr. Thrasher. Okay, so Dr. Meigs, we've mainly been talking about the IV infusion treatment, and I know in your setting of practicing as a rural family physician, can you describe how now that the medication has been approved in the subcutaneous fashion, how this has helped your patients?
Certainly. Well, one big problem we have in a small rural hospital, if I've got somebody and they're going bad and I have no hospital I can refer them to, I'm in trouble. So our thing is, let's keep them from getting sick. And that's where the monoclonals come in. Now, when they gave us the indication a week or so ago of the post-exposure prophylaxis, that's predominantly where we're using the sub-Q. Now, we have used the sub-Q some with sick folks if the infusion center is overwhelmed or somebody's already 5 or 6 days out and the infusion center can't schedule an appointment for another 3 or 4 days. And I know how critical it is to get them in that first 5 days. We'll go ahead and hit them with the sub-Q. If they're really sick, I think it's still recommended they get the IV, but if it's a matter of getting it done timely, or they're not really sick yet, or they're just post-exposure, give them the sub-Q. It's extremely well tolerated. It does require 4 injections, but we have yet to have a single patient complain about pain or have a problem, and we're lucky so far, no side effects at all. And the ones we catch early, they get better. I mean, I would a whole lot rather keep somebody from getting sick than trying to figure out what I'm going to do with somebody who's sick and needs a ventilator and I don't have any place I can send them to.
Looks like we might have lost Dr. Arora. I might segue for just a minute because I'm going to have to sign off here in about 5 minutes. But I know we want to talk a little bit about the vaccine, and what's been in the news a lot lately is a booster. Let me, and Dr. Meigs, Dr. Thrasher can join in, but let's just talk about what that means. The whole concept of immunity from a vaccine is that it's usually robust up front, and then it can wane. And what we're seeing with Delta is that the immunity is still pretty good in terms of preventing hospitalization and death, which is what you want a vaccine to do. But as far as preventing the initial infection, it's not quite as good just right now against Delta in preventing some of that initial infection, maybe only 50, 60% effective at preventing, depends on which study you look at. But people, again, are not getting that sick where they go in the hospital. But to help bolster the immunity, we're recommending, especially for immunocompromised patients right now, to get a 3rd shot. If they got Moderna or Pfizer, get the same one you had before. But also for people who are now 8 months out from their original, even if they're not immunocompromised. And I'd advise people right now to wait for that 8 months, not just flood the centers. Why? Because you still have good immunity, number one. Number two, we're in this for the long haul. This isn't just going to be shots and done probably. COVID's going to be with us for years to come, I'm afraid to say. But once we all get vaccinated, we can keep our immunity up. And the final point is that my best estimate is that this immunity will last on average up to 12 months. But by getting your booster at 8 months, we stay ahead of the curve. If we waited till 12 months and recommended the booster, then I think the immunity strength, especially against Delta, would be somewhat limited. So this is how science works, right? This is how we apply it into real life. And we're in the middle of a war, and the fog of war, things change a little bit. That's where the boosters are coming from, but it will save lives. So first off, if you haven't had a vaccine, you got to get it. That's the most important thing, and get it now. The second thing is, if you have been vaccinated, thank you for getting vaccinated, and to keep your immunity up to speed. 8 months after your last shot, let's say in February or March, go ahead and get your vaccine. My final point is, I love college football. I know a lot of people watching this love college football. I would not advise anyone to go to a live game right now. Personally, I know they're going to have the games. I know people will be in the stands, but having 60,000, 70,000, 35,000 people all crammed together, even if it's outside, half the people in those stands are going to be unvaccinated. And if we want to get back to life as normal, where we can go to those things in a safer fashion, we need better control of the epidemic. And the way to do that is to get vaccinated. Dr. Harris, you might want to add to the booster concept.
Yeah, thank you. You covered that really well. I would just say we also agree. We hope people will wait until about 8 months after they complete their shots. I think one thing about the data that was released about a week and a half ago that sort of first recommended booster shots is that even though you do lose some of your antibody levels at or maybe a little beyond the 8 month point, and you're a little more susceptible to getting infection, you're still really well protected against serious illness and death. And so getting vaccinated sooner is, not harmful in a way, but it's really not necessary to do that in terms of protecting yourself against illness and death. Now, there's some individual situations, we've talked about healthcare workers in particular who are being exposed over and over, and I know some facilities are considering how to time that. But our recommendation is to wait for about 8 months after you take your second shot. That the date that's tentatively been set by the federal government is September 20th. And that's really about 8 months after just about anybody got their second shot. The shots were available the third week of December. So people, the first people to receive their second shot were about the second or third week of January. So it's really almost exactly 8 months later that they're going to make these available for people.
Dr. Saag, before you have to go, there's been several questions about ivermectin, and we've talked about this before. Dr. Harris put out a blurb on that. We've seen I've personally seen quite a few folks come in the emergency room sick from it. You want to comment and see if we should be using that prophylactically?
And short answer is no, we shouldn't. There are really no data that support anything. In fact, the drug company Merck that makes ivermectin for both the animals and for humans, for parasitic disease in humans, has said don't use it for COVID. I don't know recommendation we could get. I really don't fully understand where the energy is coming from about ivermectin. We know that early on there were some in vitro studies means in the lab where it appeared to have some antiviral activity. It didn't add up medically or scientifically, but that was there. They tested it, and at best, even in the best of studies, it showed just a marginal effect, but it's not really doing much. In the best case scenario, if you want to be real liberal in your interpretation, as you compare to, say, monoclonal antibody. My final point, David, the thing I can't understand, I and you guys, we sort of don't use it. And then people say, well, you're anti-ivermectin. I would be the first one in line raising my hand and say, use it if it worked. I would love to have an oral drug. Love to have an oral drug that worked. No, it doesn't work. So why would I propose to treat somebody with something that doesn't work and can do harm? And the way that it's doing a lot of harm right now is that people are going to veterinary stores and clinics and buying the animal product that's given to livestock. The dose is very different, and people are getting toxic on ivermectin. Please don't do that. The drug doesn't work against COVID, full stop. And you might read it on the internet that it works. I'm sorry, that's wrong. First in line to use it. If it did work, it does not work.
Thank you, Dr. Saag, for that. I think that's a really important message right now, as some of our third-party providers are showing us data that actually the number of prescriptions has increased dramatically in the last couple of weeks for ivermectin. And that is extremely concerning to most of us here who are trying to follow the science, follow the evidence. And there are a couple of trials out there where it is certainly not something that you want to do. You don't want to miss your opportunity if you have COVID to get your monoclonal antibody.
I'll pile on that just real quick to what Mike said. I agree. We used it. We used hydroxychloroquine to begin with. Inpatient, outpatient, used a lot of it. It didn't work. The studies finally said it didn't work, maybe harmful. We used a significant amount of ivermectin in hospitalized patients. As soon as Merck said it's not safe, it doesn't work, we obviously quit doing it, went back and looked at our patients, it made no difference. We see a lot of patients come in on ivermectin. Some are sick from the product itself with bleeding disorder or liver toxicity, and really sick from COVID. And it's amazing to me, we have a drug that's non-controversial, or a concoction that's non-controversial, that's Regeneron. Everybody agrees it works, it saves lives. Why go with something that's made for cows and pigs?
I've got one question for y'all about the ivermectin. I've got a physician in our area who is telling patients that if they've had ivermectin, they don't qualify for the monoclonal antibodies. I know of no reason that would be true.
No,
Not true.
Thank you.
no, there's not. And Dr. Thrasher and I, Dr. Thrasher and I have taken care of some physicians who were touting ivermectin, used it, got sick, and were treated with Regeneron. So that's
good. Thank you.
So there's a question that has come through about doctors who are telling their patients not to get vaccinated, and doctors who are prescribing ivermectin for their patients.
It's happening, that's for sure.
Yeah, it's very, very unfortunate. It's certainly not what the overwhelming majority of doctors are saying or agree with. It just flies in the face of the evidence we have. It just shouldn't be done.
Dr. Arora, I'm going to have to sign off, but thank you for the opportunity. I hope we can do this.
Absolutely. Thank you, Dr.
Happy to come back anytime. See you guys.
Wonderful. Bye-bye.
Thanks, Mike.
Thanks, Mike.
So another question that has come is, now with the FDA approval, does anybody have any feelings on vaccine mandates?
I think the state of Alabama is not going to do that. They're very unlikely to do that. It's not something that people in our state, I think, would accept. And so, we respect people's right to choose and make a decision, but we just, want to remind people there are good decisions and there are bad decisions, and choosing not to get vaccinated is not a good decision. It appears that employers are going to have the ability to decide if people get vaccinated or not who work for them. But perhaps not the public or clients they deal with, but they certainly probably can make those decisions with their own employees. I think we're also likely to see maybe some large events, maybe concerts or games or ball games or those kind of things where people maybe don't have to be vaccinated, but they might have to have a negative COVID test to attend if they don't want to be vaccinated. And so to me, those things make a lot of sense. If people, are adamant that they don't want to be vaccinated, then they have that choice. But at the same time, we all have to be responsible and not put other people at risk. And so I think it makes sense to get tested and show that you're not a risk to other people.
And the vaccine is the way we prevent it. We've been talking today about treating and preventing serious illness, but the vaccine is what treats. The monoclonal antibodies, they don't prevent, they just treat. So the way you prevent it, you get vaccinated.
Dr. Meigs, you're exactly right, because the monoclonals, once you get COVID and you get treated with the monoclonal, it's not going to be in your system for a long period of time. The vaccine is the only way to really protect yourself. Okay, there's a question about why does the CDC not have current Alabama data regarding COVID up to date? Dr. Harris?
I don't know what they would be referring to. I don't know. Everything that I know of that we have submitted to them is updated regularly and always available. If the person who entered that question wants to be more specific about it, I'll certainly try my best to answer that.
Okay. And then another one saying, can you please give us some suggestions for helping providers that continue to prescribe a long list of vitamins and supplements, as well as ivermectin? We're seeing pockets all over Alabama that this is very common. Do you think regulatory boards or ADPH could issue a statement on this? Can we create a non-hospitalized outpatient algorithm?
Oh, I'll just say we don't have any regulatory authority over physician practices. That's an authority of the Board of Medical Examiners. We certainly have tried to educate people in a really big way, and including what we call our health alert network messages that go out to providers, as well as press releases to the public about what's acceptable and approved and what's not. I think the idea of just having a standard outpatient treatment protocol is a good idea. I appreciate someone bringing that up. We'll certainly consider doing that.
Okay.
Aurora, I could answer that too. I've just recently submitted a treatment protocol. I think you've got it. Dr. Harris has it, and I've sent it to a lot of folks. It's actually on Facebook. I was very hesitant to do that because any doctor can prescribe what he wants to. It's not saying that I am perfect, but I really honestly believe what I've got there is the state of the state right now of this. Like I said, I've used a hydroxychloroquine. I use ivermectin. I used to give a lot of vitamin D, zinc. These things we didn't know back 6 months ago, but frankly, the studies have showed all those just simply do not work. My protocol is real simple. You get the infusion first. I give a full 325 aspirin a day, and I put them on budesonide day one, twice a day for a month. And I won't go into the details why, but there are good studies that support this data.
And Dr. Thrasher, can you comment on the use of steroids? I know a lot of patients go to the, the urgent care or see a doctor before they see you once they end up in the ICU. Can you describe some of the anecdotal stories that you've heard from these patients?
Yeah, that's a sad thing because Dr. Saag and I did our first video for Masson December 18th on this very thing. We talked about the first monoclonals and the steroid. How this started, we learned early on that steroids in hospitalized patients with COVID, they did better. The survival was better. Well, that was extrapolated to the outpatient. It said if it's good for the hospital, it's got to be good for the outpatient. We started using those steroids from day one when people got the symptoms. And like Dr. Saag said, the first week, the virus circulating around your body makes interferon. Interferon is good. Okay, it attacks the cells. Now, if you give steroid those first 6 days, now you feel great. You feel great. But then you fall off the cliff, and then the cytokine storm starts on you. You want those steroids on the second week. I just, you may have seen a lady who was on TV in Fairhope was transferred from Thomas Hospital to UAB. I saw her in the office today, and I was confused. I said, you were on the ventilator within 5 days. As it turned out, she went to a urgent care 2 weeks earlier, was given a Z-Pack and steroids without being tested, felt great that next week. Then the second week, she started feeling bad again, and then boom, she's in the hospital. Once you're on steroids those first 6 days, you have a great chance of doing poorly or dying. And that was one of the reasons we've lost a lot of patients last year before we knew this. So again, if the patients go to urgent care, the doctors, and they want to give you steroids the first 6 days with symptoms, please ask for a second opinion.
Okay, so this question is again back to some of the technical issues causing delays in the reporting that we've seen recently. They've said this has happened the 4th time since July 30th. Scott?
Yeah, I mean, I think we sometimes have days where the dashboard doesn't update, and I don't have a better explanation other than to say they're IT problems. We've been running these dashboards now nonstop for a year and a half. We're using systems that, we've had for 10 years, before that. And now we're dealing with huge numbers. When we had a few hundred cases a day, when we had a few thousand cases cumulatively, it was a lot easier to do. Now that we've got, 660,000 total cases, we're having double-digit deaths every day. We're having thousands of new cases today. It's just a little bit more difficult to do. So, we certainly would love to modernize and update our information systems. That's been on our wish list for a long time. We need help from the legislature to do that. And this is a great example of why we need to do that.
Yeah, having just, organized the Pandemic Response Committee on the Medical Association side and running through a lot of that data, I mean, we certainly are one of the most, if not most poorly funded public health departments. And so these are certainly upgrades that we would like to see. Okay, a couple more questions regarding the monoclonal antibodies. Do we have an adequate supply of Regeneron?
I'll answer that. When I first I talked to the vice president of Regeneron when the governor gave us emergency authorization, which kind of opened our doors, I asked him, I said, are you going to give me all the product I need? I didn't ask him once or twice, but several times. I've talked to several Regeneron people. Dr. Harris has, and they've guaranteed us we'll have all the supply we need, so I'm going to hold them to it. Dr. Harris, you have anything to say about that?
Yeah, you're exactly right. We have plenty. Supply is not an issue. I think just about every state can get as much as they want.
Okay. I would say now, if somebody wants to begin to give it, they do have to set up an account with the distributor, with Amerisource, and get certified to receive the product. But that's easy enough to do, and I would encourage folks to do it, because this is our first line treatment for these folks, especially before they get sick. In those first few days, it makes a difference.
And especially for you, Dr. Meigs, when there's no hospital to send them to, it makes a big difference. That goes along with this question I think you can answer. Do you recommend asymptomatic vaccinated people with comorbidities who test positive to get the monoclonal antibody, or do you only recommend this for people who become symptomatic?
If they test positive, give it to them before they get symptomatic. We're trying for them not to get sick, not to see how sick they can get.
Mm-hmm.
Yeah, good point. Very good point. Okay. How many infusion centers, Scott, I know you went over this at the beginning, but how many infusion centers are open in Alabama for the monoclonals? And are we considering increasing the number of centers for the state?
Yes. So there were, I think, as of this morning, there were about 151 locations. These are not, giant drive-in state-operated infusion centers. These are providers. Many of them are hospitals. They're urgent cares. They're individual physicians' offices, like Dr. Meigs is talking about. And so this is, again, I think it's important for people to understand this is not a trip to the grocery store. This is actually a medication that a physician is going to prescribe for you based on your need for it. And so the best way to find out how to get this treatment if you need it is to talk to your healthcare provider. If you don't have a doctor, if you don't have a relationship with a provider, contact the urgent care in your area. Many urgent cares are doing these as well, or they can certainly connect you with a place that can do it.
Yeah, one problem you get with everything right now is staff shortages. I mean, it takes staff to do these. I mean, the IV infusion, some of the patients going to be with you for 3-4 hours. With the sub-Q, they're going to be there for an hour and a half. It's you got to have a space and you got to have a person. So that's a limiting factor.
We have reached out to other folks and had discussions with them. There are some other healthcare professionals that have the ability to give this, although they're not actively doing that right now. So we're working on plans to see if we can do that. But we're also just trying to hire staff. We're trying to find resources from out of state that can come to Alabama and help set these up. One of the bigger groups is negotiating with 6 different hospitals right now in order to be able to set up infusion locations. We've got another vendor that's looking at a couple of other locations. So we're trying to find people who can do this for us. But as Dr. Meigs said, there's just not enough staff to go around.
Dr. Harris, Georgia's governor has deployed the National Guard to help with hospitals and healthcare workers during the surge. Is this something that we would consider here in Alabama to help with hospitals and also making sure we have enough people to infuse the monoclonals?
Yeah, so, ultimately that's a decision for the governor to make. The National Guard have been terrific partners for us. They have just done amazing jobs, and they've helped us with things like transporting equipment around the state. They've been part of our data collection. They actually ran and operated the dozens of vaccination clinics that we did in the Black Belt and in the Wiregrass parts of the state back in the spring and in the summer. So they've done a terrific job. It's not as simple, though, as I think many people see the Guard as just some available source of manpower sitting there waiting to be used. A lot of times they are, but remember the National Guard was activated for 1.5 years nonstop and until just this past month, until July, when that activation finally ended. The people who work in the Guard, most of them are just ordinary people like us who have full-time jobs. And yet most of them spend 1.5 years working on the response. So it is challenging just to activate them again and pull them away again. For those Guard members that have, actual medical training, people who are physicians or nurses or paramedics or others, they're all employed right now in Alabama. I mean, almost all of them. They're not. So in order to use them, we would be activating the Guard, pulling them out of their jobs that they're doing now, and then trying to find a place to plug them back in. It is possible that you could perhaps train, just unlicensed people who don't have medical training to administer these medications, but that certainly wouldn't be our first option.
All right. Well, I think we are almost out of time here. I appreciate everybody contributing to the discussion of monoclonal antibodies. Again, we want to stress that there are multiple layers here at play. So we recommend for you to mask. We recommend for you to get your vaccine. We recommend for you to know about the monoclonals, not miss this opportunity. It's a very narrow window. And, once you get hospitalized, once you're short of breath, you do not qualify for this treatment. And right now we don't have hospital beds. And the monoclonal antibodies have been shown through multiple studies to decrease hospitalizations by over 70%. So we really need to put all this information together through the experts that we had here today and advocate for your family's health and for the people around you. Thank you.
Thank you.